speech.
Ladies and gentlemen, distinguished guests, I would like to use this opportunity to share what I have been done during the 4 years of my PhD trajectory. My PhD research entitled In the Pursuit of Universal Access, Inequalities in Healthcare Utilization in Indonesia. So what is universal access to healthcare? Access to healthcare is undisputedly a basic human right. So everyone should be enjoy healthcare whenever they need it, irrespective of their background, such as socioeconomic status, race, gender, and ethnicity, place and place of residence. This factor should not be the barriers to use the healthcare when people need it. Within the concept of universal access to healthcare, ideally, everybody who have equal need of healthcare should have equal access to healthcare and use similar amount of healthcare. However, most of the time, this is not the case in the real world. It is quite often that people with different background enjoy different access of healthcare, although they have a similar needs. This is called inequality in healthcare. Just like shown by this figure, if two individuals who have a different background, for instance, one individual is rich, one other individual is poor, and these two individuals have the similar need of healthcare, they are contracting the same disease with the same severity, they should actually enjoy similar medical treatment at a similar amount and at similar time. But if one of the individuals, for instance, the poor one, enjoy less amount of medical treatments because of his or her backgrounds, the differences in the treatment that received by this individual called inequality, as indicated by the darker box. The measurement of this inequality will be central of my research, my PhD research. Is inequality in healthcare a global health problems? Evidence show that in high income countries, where most people are insured for almost many decades, the inequalities in healthcare is still a major issue. There is a large inequalities in the use of secondary care, such as a patient visit to the specialist, and also in the use of preventive care, such as cancer screening. In low middle income countries where data are limited and most of the people are uninsured, many evidence on inequalities in healthcare focus on the reproductive, maternal, and child healthcare. The most recent evidence show that large inequalities in the use of pregnancy checkup and also skill attended delivery or delivery with the trained health personnel such as midwife and doctors. What about Indonesia? Indonesia is a very large country with very diverse backgrounds. It has the 4th largest population in the world, consists more than of 70,000 islands with more than 300 ethnic groups and 700 local languages. In terms of health problems, Indonesia have double burden of disease in terms of infectious and non-communicable disease in the same extent, high maternal deaths, double age of nutrition problem with obesity and malnutrition happen at the same times, and also some populations still experience lack of access in the clean water, basic hygiene and sanitations. In the characteristic of healthcare system, there is a mix of public and private healthcare systems with low health expenditures compared to neighboring countries. Only 70% of the population are insured and low investment in healthcare infrastructures. So Indonesia has all the ingredients to have large inequalities in the use of healthcare. However, the evidence to support this, to show the inequalities are still fragmented and also limited. So the aim of the thesis is first, measure inequalities in the healthcare use between socioeconomic groups, for instance, poor and rich, and their changes over time. Second, measure inequalities in the occurrence of non-communicable disease and the use of NCD-related healthcare between socioeconomic groups. Third, measure inequalities in the use of healthcare between population living in different geographical areas and the possible contributing factors. The following slide will summarize the main findings of my research. In terms of socioeconomic inequalities in the use of healthcare, our findings show that the richest compared to the poorest 7 times likely to use specialist care, 3 times likely to use inpatient cares, and 11 times likely to get blood glucose tests. With regards to the changes over the time, the inequalities in outpatient care utilization is continued to decrease from 1993 to 2007, but slightly increased from 2007 to 2014. For inpatient care use, the inequalities is slightly increased from 1993 to 2000, but continue to decrease from 2000 until 2014. For inequalities in the use of NCD-related healthcare, the richest compared to the poorest 2 times likely to get hypertension screening and medications, 3 times likely to get diabetes screenings, and 2 times likely to get diabetes medications. For geographical inequalities, our findings show that if an individual moves from one district to another district randomly, he or she will experience the change in healthcare utilization for about 60%. What actually contributes to these inequalities? The use of healthcare is influenced or determined by 2 major factors: supply side factors and demand side factors. Supply side came from the providers, demand side from the users. The interaction between 2 factors will be determine the use of healthcare, and obviously can be seen in the interaction between affordability and ability to pay. For instance, if there is a variability in service price, so between regions, this will influence the affordability of people who live in different regions to use healthcare. But if these differences can be remedied by their ability to pay, if both population live in these different regions are insured. So based on our findings, we recommend some policy implications and recommendations. First, it is crucial to address inadequate ability in secondary care, particularly in rural and remote areas. Second, it is important to strengthening the primary care systems, which may help reduce the burden of secondary care. Third, it is important to expand the reach of national insurance, particularly for the informal sectors. And fourth, improving the referral system for the secondary care that will be beneficial for people who have the low socioeconomic status. I would like to conclude these presentations by acknowledging my sponsors who provide financial support for my PhD research. This PhD research is funded by Indonesia Endowment Fund for Education, LPDP, Ministry of Finance, Republic of Indonesia. Thank you very much for your kind attention.
Wij wachten nu nog een paar minuten voordat we officieel beginnen. Maar de pedel zal dan ongetwijfeld het startsignaal dadelijk geven. Ja.
Professor Prince Dreesen, it's 10:15.
Thank you. Ladies and gentlemen, welcome to this special meeting of the Doctorate Board of the University of Amsterdam on the occasion of the Ph.D. defense of Mr. Mulyanto. Dear candidates, to open the discussion, please read aloud the first part of the formula.
By authority of the Rector Magnificus and the Doctorate Board of this university, I shall, during this hour, in order to obtain the doctorate, publicly defend my thesis entitled In the Pursuit of Universal Access, Inequalities in Healthcare Utilization in Indonesia. I entreat all those who wish to voice criticism of the contents of the thesis to do so in a truthful and lucid manner so as to provide an opportunity for an ordered exchange of views.
Thank you. Are you ready to start with the defense? You're ready to start?
Yes, I'm ready.
Okay, thanks. Then the defense will start by Professor Coblentz. Professor Coblentz is professor in global health at the University of Amsterdam. Professor Coblentz, the floor is yours.
Thank you, Madam Rector. By virtue of my rights, but not without permission of the Rector, I would like to discuss the content of your thesis with you, dear candidates. But obviously, I first want to congratulate you, yourself, your family, and your supervisory team with this impressive thesis. It reminds me of when I was a few years back in one of the major referral hospitals in Jakarta. I walked into the main hall, and what I saw was a whole battery of ATMs, cash dispensers. And I thought this tells us something. I made a photo, I still have it. And I think what it tells us is that there are inequalities in healthcare utilization that have a much broader basis than health-seeking behavior, for example. And I think your thesis shows this. You've analyzed that in the extensive breadth with very carefully analyzed survey data. So congratulations on that. I wanted to discuss with you those survey data and actually the methodology of methodological issues. And I first have a very general question which relates to one of the two surveys that you worked with, the Indonesia Family Life Survey. And my question to you is, how exactly was the sampling done for the survey? Was it multi-stage? Was sampling done in some of the stages PPS, for example? Maybe you could enlighten me a bit about this.
Actually, esteemed opponents, thank you for your kind words and thanks for the questions. I use one of the data source of my PhD thesis is Indonesian Family Life Survey. So it's actually a national survey that conducted based on other surveys. So the sampling frame using the National Socioeconomic Survey conducted by Central Bureau of Statistics of Indonesia. So it's used the sampling frame of it's a multi-stage cluster random sampling. So it's for the National Socioeconomic Survey, they use all the provinces in Indonesia, but the Indonesian Family Life Survey only chose 13 provinces with the consideration of those provinces are representative, largely representative of Indonesia, so they actually didn't 100% national representative, but about 83% representative of Indonesian populations. This is done because the depth of the survey is much deeper. They collect much more data than the National Socioeconomic Survey, so it is much more difficult to cover all of the province in Indonesia. So they only use 30 provinces, but it's multiple multi-stage cluster random samplings. So the samplings go to the province first, and then they select all of the most of the district of the province, and then within the following the sampling frame that already there from the National Socioeconomic Survey, and then this the stages will be done until a sub-district, and then they choose the block, the household block from the sub-district level.
So something like a four-stage sampling, so a rather complex sampling. So it is a cluster sampling. So that means that there will be design effects. So how did you take design effects into account when estimating your standard errors? So for example, for your p-values.
From the design, we know that actually the design will be can be oversampling in some population or undersampling in some population, but we put weight on the every sample that we get. So when we include the weight of the sample to the calculations, that is actually what we consider as the effect of the sampling.
If I may interrupt you, so that's clear. So you weighted the sampling for departures from the sampling frame, but my question is different. My question is about the design effect due to the cluster sampling. So you will get the phenomenon that within the clusters, individuals or households are more equal than they are when you would compare them between clusters, which has consequences for your standard error. So did you do some sort of adjustment for your standard errors? Did you use random effect models, or did you do a survey? Did you use robust standard errors, for example?
No, we don't. We didn't do adjustment for the standard errors. So we just take into account the weight for the sampling and then apply the analysis, statistical analysis into the data.
Okay, then thank you for that answer. So I would like to take you then to chapter 3, and it's actually a question that is a bit related to the answer that you just gave about weights and so on. So on page 55, so this is the chapter on trends of socioeconomic equalities over time. And on page 55, you write the following: the number of respondents increased over time because the following surveys included new respondents who had been part of another household in the previous survey, but who were now part of a new household, for example, due to marriage. Is my understanding correct that the same households were sampled as in the first survey round in 1993, also in the subsequent survey rounds? So are we continuously looking at the same households?
The same household is also included in the subsequent survey. So the Indonesian Family Life Survey actually is a longitudinal survey, but right, we can treat it as a cross-sectional survey actually. So from the guideline from the RAND corporations that developed the survey, they show that this data can be analyzed cross-sectionally or also longitudinally. So
yeah, so that's indeed what I was looking for to hear, for whether it was actually because you treated them as repeated cross-sectional surveys, whereas it is in fact a longitudinal survey. Well, that's all fine, but it may have consequences for the representativeness of your sample over time. So to what extent do you think that happened, and what did you do to adjust for that or take that into account?
So when we treat the sample as a cross-sectional study, we follow the guideline from the RAND corporations as a provider of the survey, and they suggest to use a different way that treat the sample, whether this is longitudinal or whether this is cross-sectional. Right. This weight of the sample will correct the effect of for instance, the effect of overestimations that due to the number and the addition of the samples in the subsequent survey.
So am I right that these weights were different for the different survey rounds?
Yes, yes.
Okay,
so for each wave there is a different weight of survey, there is two type of weight, whether we try to use it cross-sectionally, analyze the data cross-sectionally, or we try to use it as a longitudinal data.
Yeah, Madam Rector, is there still time for a brief question?
No, I'm sorry. There is no time.
Then I thank you very much for your answers and give the word back to the Rector.
Thank you, Professor Coblentz. Then the defense will be followed by Professor Westert. Professor Westert is Professor in Health Service Research at the Radboud University in Nijmegen. Professor Westert, the floor is yours.
Thank you, Ms. Chairman. By virtue of my right and with permission of the Rector Magnificus, I would like to discuss with you the content of your thesis. Dear candidate, first I'd like to congratulate you and your team with your thesis and all the work that has come to an end now. It is not a surprise to me that with Professor Kunst and Dr. Krinkels in your team, you delivered solid scientific work. I have read it with great pleasure, but still there are some questions and issues that remain, and I'd like to ask you some things about this. I have a general question for you and also one on chapter 4. But first, a general question. It seems that you assume that access to healthcare is the most important driver of inequalities. And in your layman's speech, you unfolded the concept of access in 5 different dimensions: approachable, acceptable, available, affordable, and also appropriate. These are 5 very important things for access. But my question is about quality. What do you think about quality? Of course, access to care is prerequisite for healthcare in itself, but what about quality? Don't you think that people lower on the societal ladder will have the same quality as the ones higher on the ladder? And doesn't this underestimate the real inequalities that you found in your study? Can you elaborate on this a little?
Actually, esteemed opponents, thank you for your kind words and for the questions. As I mentioned, there is a quoted from the model from Levesque that there is a 5 dimension of access, and what about the quality? Inequality in healthcare, inequality of healthcare. Unfortunately, we don't have a solid data to analyze the quality of the healthcare, whether this is actually happened in Indonesia. But from the dimension of the last dimension, the appropriateness, I think quality is part of the appropriateness dimension. So should be later than the use of healthcare. And in the stage of Indonesia, in the current stage, I think we even didn't talk about the quality because the use of the access is still very limited. Of course, it is important to discuss the quality because, as WHO said, that actually the low quality healthcare is unuseful. I mean, it's wasteful of resources, and if you don't do the quality, if you don't provide the high quality healthcare, it's inefficient actually. So, but I think there is a huge. I think I suppose that there is a loss in quality healthcare, inequality of healthcare, because we can see from the distribution of facility, for instance, it is quite unequal between and to prove this kind of assumption of suspicion, we should look at much more detail on the specific healthcare use that might be can provide whether the low socioeconomic status receive less quality healthcare than the high socioeconomic status.
Okay, thank you. So if I understand you right, you say access first and quality comes later for the stage of research in Indonesia. And I think I would like to congratulate you that you did a tremendous job in mapping the access to care in Indonesia. And we both agree that quality comes next. So I'd like to move on to chapter 4, and I will have some questions on page 83 and 84. In chapter 4, you compare inequalities in self-reported health and health assessed objectively. You report that self-reported hypertension or self-reported asthma is not a good measure of whether or not a person has hypertension or asthma. As a consequence of this, inequalities in self-reported health are underestimated if you stick to self-reported. On page 84, you explain this by stating, this is probably associated with the low sensitivity of self-report across all CES groups, and in particular in low CES groups. Low sensitivity in your study means that the number tracked via self-reports is low compared to objective assessment. Now let us look at table 4 on page 83. First of all, I see no clear differences in sensitivity across CES groups, at either assessed with education, income, or urbanicity. Do you agree with this? Is there any difference on the dimension of CES compared to looking at sensitivity?
Well, if we look at the table 4, the difference is not so large actually, because it's only 5%. But if we look at but I think if we look at the first, the lowest socioeconomic status,
yes,
from the for instance, from education level, primary to the highest socially, so the difference is quite large. So there is
you mean on the quintiles?
Yes, in the quintile, the income quintile. So if you look at the first and then the fifth, and the difference is quite large, I think. So
I would say it's very moderate, I would say. But still, it's intriguing to see that the differences are so small. And I was thinking about this. How can you explain this? I did a similar study in the Netherlands looking at self-reported health by patients that were listed to a GP practice. And we also measured what the GP practice also recorded of their patients. And we made this comparison between self-reported and GP recorded. And we found no difference at all. So the health inequalities assessed by self-report versus the inequalities assessed by the GP registry were more or less similar. So I can understand that Indonesia is in a different phase of healthcare development, but I'd like to learn about these differences, and I would like to hear your thoughts about this. What is behind this?
well, we propose at least 5 possible.
Can you be very shortly? So in principle, the time is over.
There is a 5 in our interpretation. There is 5 possible explanation related to why the self-reported is different with the objective assessment. But one of them, I think, is a different access to healthcare. If people have a different access to it, because to report disease, you have to go to you have to be diagnosed by trained health personnel. So this is huge difference between low socioeconomic status and high socioeconomic status in Indonesia. And with that, if an individual know that he or she have a disease, then he or she cannot report it. That I think what the most main explanation about my findings.
Okay, thank
Sorry,
you
I
very
have
much.
to interrupt you.
Thank you.
Thank you, Professor Westert. Then the opposition will be followed by Dr. Howling. Dr. Howling is an expert on global health at the Erasmus University in Rotterdam. Dr. Howling, the floor is yours.
Thank you. Dear candidate, by virtue of my right and with permission of Director Magnificus, I would like to discuss with you the contents of your thesis. I've read your thesis with great interest. I've basically read it from A to Z, and I really like the work you've done. You examined inequalities in healthcare use for non-communicable diseases from many different perspectives, describing the magnitude of inequalities, how they change over time for different types of care, preventive, outpatient, secondary, examining private sector, public sector, demand and supply side factors. So you've done a lot of work. And I was wondering, on the basis of that broad evidence base that you've generated, what would be the top priorities for you for reducing inequalities in healthcare use in Indonesia? And I saw in your slide that you already give some general policy recommendations, but I was wondering if you can make that a little bit more specific. So what would positive change on the ground look like? And if you can mention then a handful of things that you think are really very important, I would be interested to hear that.
Esteemed opponents, thank you for the kind words and also for the questions. I think the practical implication of my thesis, the finding from my thesis is, for instance, to address the inadequacy and unequal distribution of secondary care, we should, in rural and remote areas, we should try to have a different perspective or different strategy to solve that. Currently, Indonesian government try to solve everything by the government hands. It means that it's become the responsibility of the governments. I mean, they regulate, they also implement the regulations and also try to provide the service itself. I think it is, and it's not been so successful because we have a limit, the government has a limited capability to do that. I think it is time to try, for instance, public and private partnerships to improve the secondary care in rural and remote areas. A model like the healthcare outsourcing, maybe. So we can use the private company or private not-for-profit organizations to provide the healthcare with a certain contracts that guarantee the durability and the sustainability of healthcare in the rural and remote areas. At the current time, if government try to do that, they have a problem with for instance, the turnover of the health personnel. There is a very high turnover of health personnel in rural and remote areas. If we can have some kind of contract with private organizations, we can have much more sustainability to become the responsibility of the contracted organization to provide it, and we don't have to have the problem like no doctors or something like that, because they have to guarantee the sustainability. And the other thing I think is about financings. We have to, the problem with health insurance in Indonesia and current national health insurance in Indonesia is about the informal sectors. And we have still, so the current national health insurance should change the premium policy, I think, and try to provide some kind of partial subsidy for the informal sectors in order to make those those population segments much more interest to join the national health insurance. So I think that's two things that may be something that can be considered by the policymakers in Indonesia.
Yeah, thank you very much. So you mentioned, so in the first part of your answer, you mentioned the role of the private sector. And actually in your thesis, what you also see in terms of outpatient care is that the private sector seems to take over the role of the public sector. So public sector use for outpatient care declines, for private sector it increases, but nevertheless what you see is also that inequalities in private sector care are still huge. So under what conditions can an increase in use of the private sector lead to reduce inequalities in healthcare use? So under what conditions can the private sector help to reduce inequalities rather than increase them?
Well, it should be under the tight regulation from the government. I mean, the agreement between the contract between the government and the private health provider should be very, very, very tight, very detailed, and also explain what is the responsibility. And if we look at it is true that the role of the private healthcare provider is getting increased in Indonesia, but it seems that the distribution still unequal. I mean, because the economics, the larger economic scales in the cities and others urban areas, they still concentrated on this region. So governments provide better incentive for the private sectors, and then and I think one of the best practice so far for the rural and remote areas is faith-based or religion-based institutions. They are actually doing a very good job in rural and remote areas. We can try to start from these kind of organizations, try to design more incentive and more structures that can extend their capability to provide much more wider and better service.
Thank you. I think my time is up, so I give the word back to Director.
Thanks, Dr. Howling. Then the opposition will be followed by Professor Willems. Professor Willems is Professor of Medical Ethics at the University of Amsterdam. Professor Willems, the floor is yours.
Thank you very much, Ms. Rector. Dear candidate, by virtue of my right and with permission of the Rector, I would like to discuss with you the contents of your thesis. But before I do that, I will also extend my congratulations with the work that you did. It's really a very detailed and comprehensive, comprehensive account of health inequalities in your country, especially health care use. I think it will be a real source for policy making in the future to improve coverage and ultimately to improve the health of the Indonesian people. But I would like to discuss an aspect. You won't be surprised that I will start talking about the role of ethics in all this, which doesn't get a lot of attention in your book. So I'd like to challenge you a little bit, and I'd like to do that when in talking about your chapter about regional differences in healthcare use. You found there that service availability in itself could not explain differences in healthcare use between regions. And you said that you should also take into account pricing and service responsiveness. Now, responsiveness is a concept that's used a lot in ethics as well. It's not only an economic concept, but also an ethical concept. It's in the Hippocratic Oath, and it's a bit all over the place, I would say. So it's an ethical concept, and it made me think made me want to ask you what you think the role of ethics could be, because what you say in that chapter 2 is that the responsiveness may also have to do with the behavior of healthcare professionals. And you're speaking about financial incentives there. And my question would be, didn't you forget a bit about other types of incentives that maybe given by, for instance, ethical codes of the profession, maybe ethics education? Or do you think, and you might think so, I mean, I'm doubtful myself, do you think that ethics is rather useless as long as the system encourages inequalities? So I'd like to have your views on what the role of ethics, and especially ethics education, could be in the light of what you found.
Highly esteemed opponent, thank you for the kind words and for the questions. I mentioned that responsiveness is maybe can explain some of the differences in the healthcare use between regions, and I guess that why I mentioned financial incentive, because more empirical evidence on financial incentive is actually very clear that when medical doctors behavior or physician behaviors is sensitive to the change in the financial incentive. That's I think there's a huge or considerable amount of empirical evidence that show that. And in Indonesia, I think in practical, this is also the case. So, but I know that it is not the only one where there is still that I think because at that time, actually, the financial incentive in Indonesia is still not up to the standard of medical doctors. It means if compared to other countries, the standard of the financial incentive is way below the other countries, and also the work burden is
maybe
also.
I can interrupt you if you don't mind. Do you suggest maybe that as long as the financial compensation for healthcare personnel is insufficient, that it's not very fruitful to speak about ethical obligations that they have towards the population and the needs of the population?
What I mean is that if we can solve the financial incentive problem, then I think we can address one of the factors or variables that actually influence, and then we can go on whether there is still ethical problems there. I mean, there is a problem related responsiveness that maybe can be related to ethical problems there. If
right.
So, we can remove the possibilities. I mean, although it's not fully omitted, but I think we can, if we can solve the financial incentive problem, then we can continue with other things, factors, if there is still variation in the responsiveness of.
Okay, thank you for that answer. I mean, it's very clear. You say you should solve the financial issues first, and then we can talk about ethics. It's a bit like access and quality. Start with the financial, start with the access, and then talk about the ethics. I'm not sure I completely agree with you, but it's a clear answer in any sense. Maybe do I have time, Rector, for another small question?
Yes, you have.
Thank you. There's another issue that I found very interesting about this geographical inequality that you mentioned, which was about the role of distance, about travel time. You say that travel costs didn't very much influence the healthcare use, but you said travel time does. So if people have to spend a day to get to a healthcare service, then they don't do it. When I'm, as you know, I'm in Indonesia sometimes, and what I see is that everybody all the time is on their cell phones, on their computers, their iPads. So they're living half their lives, in my impression at least, on the internet. So wouldn't it be, because your idea about this distance issue is that services should get closer physically to the underserved people. Wouldn't Indonesia be a very good place where care at a distance through e-health and through internet would solve at least that distance factor in healthcare access inequality?
Thank you for the questions. I think telemedicine or telehealth or something ICT-based solution can be considered as one of the potential solution. But we have to be very careful, because I'm not sure that that all of the geographical areas in Indonesia have the same infrastructure of ICT. So potentially it can be something that we can, I mean, if we try to use telemedicine, we have to be very carefully and consider whether the ICT infrastructure is also equally distributed among geographical areas in Indonesia. If we don't consider that, I'm afraid that will increase the inequalities, because only people who have access in ICT use more healthcare than those who actually need the real healthcare actually. So that should be, I don't think technology is a high-tech is the only solution the biggest solution for solving the geographical inequalities in Indonesia.
Okay, that's a very reassuring and thoughtful answer, and I give the word back to the rector. Thank you very much for your answers.
Thanks a lot, Professor Willems. Then the session will be continued by Professor Klasinga. Professor Klasinga is professor in social medicine at the University of Amsterdam. Professor Klasinga, the floor is yours.
Thank you, Madam Rector. Dear candidates, by virtue of my rights, but not without the permission of the Rector, I would like to discuss with you the content of your thesis, but not without complimenting you for a solid piece of work. And in that compliments, I also want to include your thesis advisors. My line of questioning is about what you mentioned in your thesis. You're producing materials that should contribute to evidence-based policymaking and evidence-based decision-making. And my first question would be, one of the limitations of your work, which is really set in the ground, is that it's basically on data that cover the situation up till 2014. And we both know that Indonesia has set up a lot of initiatives in social security, 2014, and in universal health coverage, the big introduction in 2019. If you would have to advise a national policymaker how over the coming 4 years to evaluate access to healthcare utilization, what would you advise, and to what extent would you rely on surveys versus the data that now become available through your national health insurance?
Highly esteemed opponent, thank you for the kind words and the questions. It's true that we now have a national registry-based data from our national health insurance. It's covered about 220 million populations now, almost 80% of our populations. But I think from this data, we can look in particular that some of specific specific type of healthcare that might be we can assess whether the inequalities in more accurate and precise. I mean, for the use of specific related of healthcare, but there is also some points that we have to take into account cautiously if we use this data. I mean, there is still about 40 million population who are not included in the national health insurance until now. So this is, I think, a significant number. So we should combine between also survey data and the national health insurance data to look into much more detail what kind of specific health problems that actually experience inequalities and should be addressed as a priority.
I agree with you, but could you elaborate a little bit more? For example, in the national health insurance data, when I look at the databases that are set up now in different Asian countries, Thailand, Cambodia, Malaysia, I don't know the system in Indonesia that well, but would I be able to differentiate volume data by socioeconomic status, health, educational status, or perhaps the place where people are living, to have a proxy of whether even within this limited amount, but as you said, it's increasing, the number of people that is in your universal health coverage insurance scheme, could I differentiate there in the use of healthcare by socioeconomic differences?
Thank you for the questions. We don't have as far as I know, the data will not show you the socioeconomic status level, but we can see from the type of the member of the national on insurance, we can see whether this is a subsidized beneficiaries, which is the premium covered 100% by the governments. That can be a proxy of the poor populations or low socioeconomic status. And for the data about the geographical, I think it's quite detailed, so we can differentiate between where they live, where they reside. And I just read some analysis from one of the universities, and even we can track the pattern of referral systems. It means that if people do not have, if some regions do not have some kind of facility, the beneficiaries should travel to other cities, and we can track that kind of a travel pattern. So we can see that in terms of geographical, there is a deficiencies in some place and other place.
So there are options there. When you want to cover the whole population, rightly so, at the moment you have a survey methodology that is, if I understand correctly, it was done every 7 years. And theoretically, then it should be done again in 2021. Would you advise the developers of your Central Bureau of Statistics about questions they should include about access to healthcare? That would really be helpful to get more information on access and utilization of healthcare based on the household survey?
Well, the current survey that I use, the Indonesian Family Life Survey, actually provide quite detailed data on healthcare utilization, including, for instance, healthcare costs and other things. So I'm not sure that actually the one thing that I should recommend to add is about the measurement of need of healthcare, because that's important for us to get a more objective assessment about need of healthcare in order to adjust with the healthcare utilizations. That's one of the deficiencies of the current data set, I think.
Okay, well, one of the things I was thinking about going over your materials, what I see in the OECD work, that more and more countries are using access questions very specifically. In the past 6 months, did you ever refrain from going to the doctor because you couldn't afford it? Or did you not pick up your medication because it was too expensive? Or didn't you go to, so are these kind of very specific practical access related questions embedded in the household survey, or will they be embedded in the next round, as far as you know?
Yeah, thank you for the question. I'm aware that the OECD and European Union now include what we call unmet need of healthcare, something like that, some kind of type question. I think that's have a potential to be included in the next phase of the next report survey. But we have to be careful with the nature of Indonesian people, because this kind of question is quite, I think it's quite tricky if you ask them to the low socioeconomic status. So we have to be a good field testing about this type of questions in order to make sure that it can provide valid data about the access to healthcare.
Oh, thank you. I'll start with the next one and we'll see whether we get an answer. You also promote.
Ora es.
We'll do that another time. Thank you.
Thank you, Professor Klaasenka. Dear candidates, the discussion is closed now, and I request you to read the second part of the formula.
Having thus concluded the defense of my thesis to the best of my ability, and pending the decision of the doctorate committee, I should like to express my sincere thanks to my highly esteemed supervisors in particular, as well as to those who have to courteously brought forward their criticism, and to all who have honored the ceremony with their presence.
Thank you. The committee retires for deliberations now.
Microfoon.
Uw microfoon, mevrouw de voorzitter.
Sorry for the interruption. Esteemed candidates, after due consideration of the thesis you have submitted, we have decided to grant you the doctoral degree. Professor Kunst is authorized to confer this dignity upon you in customary fashion.
I most willingly accept the task assigned to me by the Rector Magnificus of the University. By virtue of the power conferred on us by law, and in accordance with the decision of the Rector and the Doctorate Board of the University of Amsterdam, I hereby confer upon you, Joko Mulyanto, the degree of Doctor, and grant you all the rights pertaining hereto by law or custom. In evidence hereof, you will be presented in due time with the degree certificate signed by the Rector and the supervisors and confirmed with the Great Seal of the University. Having thus fulfilled the task assigned to me, I have the honor of being the first to address you as a doctor and to congratulate you with the dignity conferred upon you. So, dear Joko, dear Dr. Mulyanto, congratulations. This formal PhD trajectory now ends in the way it started, with a video call between Indonesia and the Netherlands. That start was 4.5 years ago. You had contacted us, the late Marie-Louise Ensigbot and me. You were interested in doing a PhD project at our department. So we met by Skype and we talked in order to get to know each other. It became clear that you were smart, ambitious and agreeable, so we agreed that you would come. And this was really a big step for you. You already had an established career in Indonesia with important roles both in care, education, research and administration. And now, in a way, you had to make a step backwards to concentrate on research and do the essential things like processing and linking data sets or writing text all over again until Dionne and I agreed that these were ready for submission. These were tedious, time-consuming tasks that required patience and perseverance. But you did show patience and perseverance. Actually, you showed much more. You were meticulous and reliable. You were communicative and responsive. You showed a sincere interest in your colleagues. And you were very agreeable, also in many meetings with Dionne and me. For us, it was interesting to hear about healthcare in Indonesia. You were, of course, the expert of us on this, not we. And it was nice to see how you used your in-depth knowledge to formulate questions that were really relevant for Indonesia and to decide on methods that are appropriate in an Indonesian setting and to interpret your results in meaningful ways for the Indonesia. And I very much hope that you will be able to further use this capacity and thus to contribute to research that is not only of high quality, but also very relevant to healthcare in Indonesia. Going to the Netherlands was a main step in your personal life. It meant that you could not be with your wife, only at occasional trips to Indonesia. It also meant that you could not see your son growing up in his first years of life. It was hard to be separated from your family for such a long time. I hope that to you, that this book was worth the effort and the pain, and I'm pleased that you can share this beautiful day now together with your family. Joko, I found it very inspiring to be working with you. This is not only my experience, but also that of your co-promoter, Dionne. She will say a word to you after the official ceremony. But I'm pleased that you and Dionne continue to collaborate in healthcare research. And it's great that you are already working on several new papers. So, Dr. Mulyanto, I congratulate you and your family on this major achievement, and I hope that this book, the PhD title, and everything you learned will help you in pursuing a fruitful scientific career. And I go back to the formula. Regard this obtained dignity as an honor and a privilege, and never forget the attendant responsibilities which you now bear towards science and society.
Thank you. It is a very pleasant duty, most learned scholar, to congratulate you, also on behalf of the Doctorate Board of the University of Amsterdam, on this newly acquired honor. And hereby, I declare this ceremony closed. Congratulations.
Thank you, professors.
Congratulations, Dr. Mulyanto.
Thank you.
Congratulations, Joko.
Thank
Congratulations,
you,
Joko.
Dr. Brunges.
Well done, Joko. Congratulations.
Thank you, America.
Congratulations. Selamat.
Yeah.
Thank you,
You did
Dr.
it.
Howling.
You did a really good job, Yoko. Selamat.
Thank you, Professor Williams.
Congratulations.
Also, Professor Kunst. Oh, sorry.
Sorry, go ahead.
Go ahead.
Yes, congratulations, Joko. Very well done.
Thank you, Professor Klesinger.
I'd like to congratulate also Professor Kunst and Paranymph with this.
Me too. Really, really good.
Okay, thank you. Thank you for that. Yeah, we are very pleased. Dionne, you too, eh?
Very well done, Joko.
Yeah.
Very well. You made us proud.
Yeah. Okay, we will have an informal meeting of our department at 11 o'clock, and then we can toast once more with Joko.
Okay, thanks.
Good.
Have a good day.
Okay.
Thank you very
Thank
much.
you.
Have a nice
Bye.
Okay.
Bye-bye.
Celebrate.
Soon, Joko.
Bye.
Yeah.
Bye.